Thank you very much. In fact, this presentation is about the experience in two countries in Central Africa, Rwanda and Burundi, who had, let's say, the national plans for maintenance of equipment and inventory of their medical equipment. I don't know how it works here. This one. Okay, so in summary, I will briefly present you what we use as guidelines for education in these countries, our experience in Rwanda and Burundi, and then come to a few conclusions. For guidelines and for, let's say, education purposes, we try not to reinvent the wheel. First of all, there is the book series of WHO, which are to which we contributed and which are extremely useful and from which you can derive immediately good guidelines and courses for the people who are involved in maintenance of equipment. Here particularly there are a few books which have to do with ICT support for equipment management, and these are also part of the WHO series. Then there are other guidelines which are available online, and these are a few that we use. How to manage series, it's very useful and very practical. And then there was a recent book by Binseng Wang, who is around here in the conference, and which is a good analysis of how to make an economical study. What is the benefit of maintenance? What is the financial benefit, possibly? Unfortunately, Binseng's book here was mainly documented by USA data, which is normal, but the framework of his spreadsheet with the adequate data from other countries and African countries, his methodology is very useful, and we hope that in next editions and with the experience of others, we will have more and more data from not only USA but also countries from, let's say, other places in the world, such as Central African countries. Anyway, his book was very useful for, oh, what is this one? Yeah. Okay. There is also the How to Manage series that we use for courses in Central Africa. First, our experience in Rwanda. We can say that Rwanda is a well-organized country regarding the health system. It is quite pyramidic, top-down. The Ministry of Health had and has, because it was removed and then repopulated, a medical device division, and they have a strategy for ICT support in management of medical devices. The Clinton Foundation was supporting them and introduced a program called MEMS countrywide to collect the data from the country, from all the hospitals, first of all the public hospitals, but also trying to include the private hospitals, and to have a database that was situated in the ministry to collect the complete content of the database of the complete equipment, in medical equipment in the country. MEMS enables local data entry. There are fortunately two versions, one for testing and education and one for production. It's a centrally managed database, and there is a rather weak user and access management system that enables all hospitals to enter data and a few people in the ministry to analyze the data. There is a high uptake because by mid 2018, we could say that about 80% of all the equipment, medical equipment installed in the hospitals was registered. So you cannot, they asked me, should we continue on MEMS or not? You cannot say, stop it and start again when you have 80% of the database of your country operational. So what was wrong with MEMS? The main thing was that they did not take enough care of the needs of the personnel in the hospitals. The database was there for monitoring and for overview from the ministry, but not to help and to assist the managers in the hospitals and the personnel in the hospital. So we made a plan so that additional modules would be made operational in MEMS in order to produce weekly reports to indicate to the maintenance personnel what to do this week, which machines to maintain, what to do, and to have a real list of actions that they should do, and a feedback mechanism to see what was really operated on, what was done in the maintenance. Secondly, there is a big problem of decommissioning, and we tried to have them imply a module about decommissioning and procedures that would enable much easier decommissioning. This is an overview of the MEMS system. It's a database, a distributed database, and it works quite well. And this is now the report that is brought every week, day by day, with labeling, clearly indicating to the personnel, of the maintenance personnel, what to do in order to maintain the equipment and do replacements, etc. At the moment, I don't have, let's say, an impact study of how it is really working, what is really performed as maintenance actions, but to do that, fortunately, next year. In Burundi, the situation is a bit similar. It's also a well-organized healthcare system. Public hospitals also sent all their information or wanted to send their information to the ministry, and here there was no support of the Clinton Foundation, but what we found was that in most of the public hospitals there was a hospital management system called Open Clinic, open source, that was operational and was running the hospitals quite completely. The request from Burundi was a bit different. The Burundis, they wanted not only to maintain the hospital equipment, but also the complete infrastructure. Hospitals have buildings, must be painted, must be repaired, roofs, they have cars, they have ambulances. This was not present in the MEMS system, but they wanted that for Burundi. So first a word of Open Clinic GA. It's a hospital management system. It's much more than a medical record system. It comprises the medical record of each patient, but it also has a complete management of the patient. It has a complete financial management. It also produces the reports for the ministry, reports for insurance companies, etc. But it had no, last year, it had no module for equipment maintenance. This module was devised and deployed. It is called the GMAO, and it was inspired by the guidelines of WHO. So it enables registration of all medical devices. The coding system was a problem because there was no freely available coding system at that time, and we are looking forward to the WHO coding system that will be released very soon, based on the Italian one, and then we will translate all the codes that were prematurely added to this system to use the international code of WHO probably next year. Because the network in Burundi is not as reliable as the one in Rwanda, it was allowed to have an off and an online operation so that when the connection is not there, the hospital is not stopped. The hospital technician can work on. It also comprises, as I told, not only the medical equipment, but the complete infrastructure of the hospital, up to every single door and window. So it's quite comprehensive. The experience was quite positive. We had a few courses based on the information and hands-on with the testing module of the GMO, and the uptake was quite immediate. The fortunate situation was that when the class was finished, the technicians went to their hospital and could immediately start working in daily practice. What is in fact missing is a good ticketing system, because the repair requests coming from the departments should be handled by a electronic ticketing system rather than by working orders that they do still on paper. This should be developed. This is what you can see as the GMO module of Open Clinic. This is a diagram, very simple. The application is in the hospital. There are about 40 hospitals in Burundi, and this is via the internet the connection to the ministry where the database is kept. So I will go to the conclusions. So in both countries we find a great awareness regarding medical equipment, especially by the people in the hospitals, a bit less by the ministries, but still by hosting the database and by keeping the data and getting reports, they are sensibilized. So the ministers are in close contact with the reality in the field. We have now a very good view of the inventory of the country, and we can see what are the problems, which equipment do better than others, and what should be perhaps standardized. Finally, a big problem is still spare parts. The companies of medical devices are very badly represented in Africa, and spare parts is a heavy burden on the budgets, and it's also a matter of choice. What should you have in spare parts? What should you invest? Or where do you take the risk to have to wait for 3 months before a spare part comes to you? Still, decommissioning is still problematic because the local regulations are very heavy and not easy to implement. Thank you.
Thank you very much for your presentation. So, due to the time restrictions, we have questions for 1 or 2 short questions. Yes, please.
What is your suggestion to solve this problem, especially in Africa?
Are used, or a few models are used, so that you don't have a need for 20 types of spare parts. Secondly, to make an analysis, to have data. First we need data to see what is useful to have as spare parts locally in each hospital. Secondly, perhaps on the provincial level. And finally, the heavy ones, maybe one for the country or with a contract with the suppliers. So but we should have data over a few years to find the optimal strategy there.
I mean, the change today's product because then next year, oh, it's obsolete. It's obsolete. We have no production. They only sell it, not producing enough parts.
Yeah. On the level of the country, we advise the country to have framework contracts with main manufacturers. And this framework contract should oblige the manufacturer to provide, as one of the rules, to provide spare parts within a given time. Well, it depends on the type of equipment, of course. Eh?
Thank you very much for your presentation. Mine is on asset management. You indicated that all the equipment is registered. I would like to know what system is in place to ensure that when you update your asset register or you do periodic auditing, which would probably maybe take a year, ensure that all the equipment that was registered is still there, is not missing. Thank you.
Yes, the ministries of both countries have inspections departments who go and visit, and they don't visit everything all the time, but they have samples. And the reports we got so far, the last months, say that what was registered is quite accurate, indeed. So of course you have some differences. You have some hospital equipment managers who are more rigorous than others. You will always have this difference. But it gives a good image, I think. The image in the database is quite correct.